The place of aspirin in primary prevention remains controversial for sure, with North American and European guidelines offering contradictory recommendations. The U.S. Preventive Task Force has issued a recommendation supporting low-dose aspirin for the primary prevention of cardiovascular disease and colorectal cancer, with some limitations, as you might imagine. So we're here today to talk not so much about the CVD, but it's more the CRC. And so this is the review topic of the week. It is in the August 30th issue of JACC, and it is aspirin and cancer. To talk about this, I'm with Dr. Carlo Patrono, who is an MD and adjunct professor of pharmacology at the Catholic University School of Medicine in Rome, Italy, and he'll soon be at his job at Perelman School of Medicine of the University of Pennsylvania in Philadelphia, too. It'll be nice to see you in the United States. Hope our weather is a little nicer there than it is here at the moment. That's why we're in sleeves. In secondary prevention, there's really less debate. We know the role of aspirin. In primary prevention, that's where it gets really sticky. So what did you set out to do when you wrote this review topic of the week for JACC?
Well, I was motivated by two things. My own research interest on the possibility that aspirin may indeed prevent some forms of cancer, perhaps through a common mechanism of action as in cardiovascular prevention. And the second is the formulation by the United States Preventive Services Task Force of a new set of guidelines that for the first time incorporate prevention of colorectal cancer.
The CVD has been mentioned before, but that was kind of new.
But this is the first time they mention prevention of colorectal cancer as an additional long-term benefit of aspirin therapy. And they define some specific patient population for which they consider the evidence sufficiently strong to give such a recommendation. And this is essentially people who are 50 to 59 years of age, who have no increased risk of bleeding, have an estimated 10-year risk of cardiovascular disease of greater than 10%, have a life expectancy longer than 10 years, and of course are willing to take low-dose aspirin for at least 10 years.
So there was a lot of negative publicity a while back related to COX inhibitors, both aspirin and other traditional NSAIDs for reducing the risk of GI cancer. It worked, but the problem was the cardiac toxicity. You addressed that in this paper, correct?
Yes. This is apparently an area where low-dose aspirin behaves quite differently from other COX inhibitors. At low doses, that is 75 to 100 milligram once daily, aspirin is essentially a selective inhibitor of COX-1 with no measurable impact on COX-2 activity. If you increase the dose of aspirin into the analgesic anti-inflammatory dose range, then you inhibit also COX-2. So the cardiotoxicity was essentially a problem of COX-2 inhibitors, and not just the selective COX-2 inhibitors, the so-called COXIBs, but also some of the traditional NSAIDs like diclofenac.
That would seem to argue vociferously for making sure it's low-dose aspirin and not just having someone take a single, absolutely adult aspirin every day.
Absolutely. It's an additional argument in favor of using the lowest dose of aspirin that has been shown effective in cardiovascular disease prevention, which happens to be also the lowest dose shown to be effective in colorectal cancer prevention.
Which is very convenient.
Yes.
So you mentioned at the very beginning, so the question I have to have is there a biologically plausible mechanism of action?
Well, that's the several million dollar question or euro question. And we have put forward the hypothesis that inhibition of platelet activation at sites of intestinal mucosal injury may be a contributing factor to the chemopreventive effect of aspirin, because at sites of tissue injury, platelets participate in tissue repair, and when they are activated, they release all sorts of things, including growth factors, various inflammatory mediators that can have effects on adjacent nucleated cells of the intestinal mucosa and turn on COX-2 expression, which is a potential mechanism for colorectal carcinogenesis. And if this hypothesis is correct, you might explain why you see essentially similar protective effects with low-dose aspirin acting upstream to inhibit platelet activation and COX-2 inhibitors that work downstream to inhibit COX-2 activity. And the problem with COX-2 inhibitors is what you just mentioned, the cardiotoxicity.
So what's the size of the chemoprotective effect? And actually, can it change the benefit-risk profile?
Well, the size that has been estimated both based on observational studies and on post-hoc analysis of randomized clinical trials of aspirin for cardiovascular prevention is about a quarter reduction, a 25% relative risk reduction in cancer incidence and long-term mortality due to cancer. Now, even a more conservative estimate of this potential chemopreventive effect, like a 10% reduction in overall cancer incidence, when added to the cardiovascular benefits of low-dose aspirin, would tilt the balance in favor of the benefits versus the risk of major bleeding.
In terms of what you would recommend to clinicians, you know, they hear this, they're now thinking maybe a little differently of aspirin because it's been bandied about and maybe sullied a bit in the last few years. What do you recommend?
Well, I would stick with the US Preventive Services guidelines because they have done a very extensive review of the evidence. What I would tell clinicians is that they should be interested in reading this review article for at least two reasons. One is because it suggests that there may be common aspirin-sensitive mechanisms of disease that are shared by cardiovascular disease and cancer. And these may open entirely new avenues of research and potential therapy. Second reason is that when they are considering starting a patient on low-dose aspirin for primary prevention, they should inform the patient of this additional information that may alter the balance of benefits and risk as compared to a year ago when these recommendations did not exist. And also in terms of the patient who is already on aspirin for secondary prevention, I think this should reinforce the rationale for staying on aspirin rather than quitting aspirin a year or two after the acute event.
And low-dose aspirin is preferred to the adult full-strength aspirin.
Absolutely.
So just once again, it's adults age 50 to 59 years who have 10% or greater 10 years CVD risk, are not at increased risk for bleeding, have a life expectancy of at least 10 years, and are willing to take low-dose aspirin daily for at least 10 years. Those are the recommendations now from the USPSTF. For Cardiol Source World News and Cardiol Source World News Interventions, please check out the August 30th issue of JACC and this review topic of the week on aspirin and cancer. I'm Executive Editor Rick McGuire.